I've been working in MS research for over 35 years. From PhD student to grandpa, I've been trying to find these MS genes. It's very exciting that we're almost there. There's an old saying in science that if you want to make little steps, compete. If you want to make giant leaps, collaborate.
MS Research Australia has created a fantastic atmosphere of collaboration. I know that we have achieved a lot, and I think multiple sclerosis is one of the few areas in medicine where there has been dramatic advances, especially therapeutic options. There is a lot more work that needs to be done. We might not have yet a cure for multiple sclerosis, but we are very, very close.
We've found the susceptibility genes, now we want to find the progression genes. There's so many reasons to think that the trail that we're on is a good one. We expect to find ways of predicting who will respond to which therapy.
We will see over the next 10 years probably 10 times the discovery of the past 10 years, and that is just going to be wonderful. I look forward to it.
Welcome back. I'm now joined by Dr. Sheila Donnelly from the University of Technology, Sydney, who's a parasitologist. I have to admit, I'm a little bit fascinated, but also a little bit, what shall we say, freaked out by what you're going to be telling us. So, what is worm therapy?
Yes, well, I'll start. Your reaction is quite normal. Worm therapy is this idea that we can give a person a live infection of parasitic worms and regulate or stop the immune response which mediates autoimmune disease. And that's not just particular to MS, we are looking at other autoimmune diseases. These are pathogens, they're worms, and they're quite large pathogens, some of them. So parasites come in lots of shapes and sizes. They infect by ingestion, burrowing through the skin, delivered by flies and mosquitoes. So there's a whole range to choose from. In terms of progressing, I guess, worm therapy, we focused on two particularly. There's a hookworm, which is a human parasite. It's specific to infect humans. It burrows through the skin, ends up in the lung, gets coughed through into the intestine, where it latches onto the intestinal epithelium, feeds on blood, and can stay there for up to 15 years. But if you have a low dose of these parasites, so in terms of worm therapy, we're talking about giving a very low controlled infection. And we have that luxury, I guess, in the Western world. So we say about 20 to 30 of these worms, and it's asymptomatic. You really don't know you have these worms. They have tested, I will say on graduate students in labs around the world, what number of these worms feel comfortable. They're obviously in the intestine. With larger doses, there are abdominal symptoms that you are carrying an intestinal worm. But we do know from all of the various small human trials around the place that certainly between 20 to 30 of these worms is quite manageable. People don't feel that they're carrying worms other than the psychological impact. The other worm that's used is called Trichuris suis, and this is interesting because this is actually a pig worm. And the reason people are trialing this is the idea is, well, we don't want to colonize with the human pathogen. We'll give a pig worm. You get them infected by eggs that you swallow in a small amount of liquid, about 2,000 eggs. Those eggs, when they reach the intestine, will hatch into a little small worm that looks like a whip. But because it's a pig worm, the human will expel it quite quickly. So it's a slightly different regime, if you like. For the hookworm, you get one infectious dose, which you then maintain in your intestine for a number of years. For the Trichuris suis, you have to get eggs maybe every 2 to 3 weeks because you're constantly expelling those worms. So they're the two worms that are currently in trial. We have some small human trials going on around the world at the moment, and they're the two that have certainly progressed the most.
Right, okay. So how do these kind of infections, how do they actually kind of influence autoimmune disease?
It's quite interesting. So parasitic worms are infectious pathogens, but they're unusual in the type of immune response that the human or any of their mammalian hosts will mount against them. So they're much bigger than bacteria or viruses. So the normal immune response that we've evolved over many, many years to protect us from infection doesn't actually work against these worms. The worms are too big, so the typical properties of your protective immune response don't work. So the theory is that we as human hosts for these parasites have evolved a different type of response. And instead of trying to get rid of these worms, we manage the infection or tolerate them, if you like. So we know these parasite infections last for maybe 15 or 20 years. And during all of that time, the immune response is very tightly regulated. The idea being that we encapsulate the worm or we repair the tissue damage caused by the worm, but that we don't have the same inflammatory response like you would see with a bacteria parasite. And what's quite interesting is, and I will, a disclaimer, I am a parasitologist, so this will be a little bit biased. But obviously, we believe that parasites have been with us as mammals for many, many millions of years. And as we've evolved as humans, we've actually evolved in the presence of these parasites. So we would argue that the presence of the parasites has, in fact, educated the immune system. So the parasites perhaps represent a regulatory arm to manage excessive inflammation in the immune system. And if we look at some of the distribution of where these worms are found in the world, in a lot of populations where these parasitic worms are endemic, so communities are infected all the time with a large number of these worms, typically we don't see a lot of autoimmune disease and even allergies. But in Western society where these worms are gone, we do see diseases caused by that unknown, I guess, unregulated immune response. So the theory then is if we replace these worms, as I said, with the luxury of choosing the number we want to be infected with and the kind of worm, but if we replace those worms, perhaps we're regulating the immune response by using these worms. In terms of the therapy and the advantage of it, so in a way they're very similar to some of the immune suppressant therapies that are currently being used for autoimmune disease. We would say that if we get the dose right and they're asymptomatic, it may actually be a little bit preferable because you get less side effects. You don't have to have lots of doses. For a hookworm, you get infected once and maybe 10 years later get reinfected. So there are positives to carrying these infectious diseases. Again, I will flag that obviously it's a luxury of Western society. There are populations around the world who are affected quite dramatically by carrying these worms because they carry a lot of them, a lot of different species in high numbers. So it does have an impact in that scenario. So with carefully managed, controlled infection, we would like to think we could possibly regulate the immune system.
Okay, so if someone is affected by, in a controlled way, as you're suggesting, is there any kind of side effects to kind of worm therapy?
Yeah, so having just promoted how fantastic it is, there's obviously a few scenarios. There's a few issues we would see in terms of using live worms. At the end of the day, they are live worms. It is a pathogen. So there is likely going to be some physiological changes, and whether we can manage those or not is obviously a question going forward. And the other, this will add to your horror, I guess, of using worm therapy. Worms need mammalian hosts to grow and mature. To collect worms from a mammalian host, there's only one place that those worms typically come out from, the intestine. Yes, and they do come along with a large amount of fecal matter. You harvest the worms, and that's the only way you can collect these worms. So they're intestinal worms, they need a mammalian host to grow. So we can't culture them in the lab, we can't culture them in cells or in tubes. So you do need to grow these worms in a mammalian host to get to the point where you can harvest the worms you would use in therapy. So obviously there's a risk of infection, purification and that type of scenario. And whether or not you could genuinely use that approach to produce a real global therapeutic would be questionable, I would say. Also, the dose is quite difficult to control. These are live infectious agents. At the end of the day, we don't have much control over how they look, what stage of development they're at. Are they all of the same? Are they all producing the same immune modulating compounds and so on? So actually controlling that dose is very challenging. And particularly in the example of the Trichuris suis or the whipworm, that's where we give people eggs. We don't know how many of those eggs will actually hatch. So you may be giving somebody a dose of 2,000, but in fact, they end up with 10 live worms. So managing that in terms of a pharmaceutical dose and a proper treatment regime is really quite challenging.
So is there any alternative to using live worms?
I'm glad you asked. So this is the work that we do at UTS in Sydney. So what we're interested in trying to understand is how exactly are these worm infections regulating or changing the immune response, and whether we can determine the factors that the worms are using. There's a combination of theories in science research at the moment really as to whether it's host signals regulating that immune response when the worm infects, or whether the worm itself is regulating the immune response. Again, being a parasitologist, I'm on the side of the worm. So we can collect these worms and collect the compounds that they secrete. And while worms are wriggling around your body trying to get to the tissue that they want to and feeding and so on, they're constantly secreting compounds. Some of these are enzymes to break down tissue and allow them to migrate. Some of them are enzymes to break down blood to allow them to feed and so on. But we think some of these secretions also modulate or regulate the immune response. So in essence, we're looking for an immune therapy derived from a parasitic worm. The advantage of that, we think, is, again, it's evolved over millennia. So very much like the R&D program of a pharmaceutical company, these parasitic worms have worked for years and years to perfect these molecules to have a very defined and very specific function. So we think if we can determine what they are, then we could perhaps make them synthetically. They could be an injectable or maybe an oral therapy. It's more challenging than it sounds. Some worms secrete more than 2,000 molecules, some less so. So it's about picking the right worm, identifying the right molecules. We've made some progress at UTS. We have 2 or 3 molecules now that have shown some efficacy in animal models of disease. So we're certainly in the very preclinical early research stage, but we do see some really nice efficacy when we give these molecules as therapeutic, I guess, so after the onset of MS in a mouse model of disease. And what's very nice about them is we don't really see many side effects. Again, we think it's because the worm has evolved to have a very specific function. The worm doesn't want to have cytotoxic effects in its host. It needs its host to survive and survive for a long time so it can complete its life cycle. So yes, I think these molecules, in theory, could actually be almost an improvement on the immune therapy. So they are regulating the immune response, but maybe more specifically with less side effects. And again, the doses we need to use, it seems we need to use quite a few lower doses, so lower injectables, if you like, of these worm molecules compared to normal immune suppressants. So certainly the early results are encouraging, but it is early stage research, but certainly something worth progressing, I think.
So it is in early stages of research, and you've outlined that there's a number of different worms, and each of these have different number of molecules. So how soon can we kind of expect a clinical kind of treatment derived from worms?
And this is a question I get asked regularly, and it's a long, hard journey. I think everyone in the room recognises that to get a compound from a lab discovery into clinic is a long journey. I think if we see nice progress in the worm trials, the actual trials with live worm infections, we have 2 that have just been completed in MS in Europe. I think if we see good data from that will certainly encourage the pharmaceutical industry and investors to recognise that there is potential in this. I think at the moment it's still a question mark as to whether worm therapy really is a place to go. But I think if we can really sell the story that these worms are researching and developing these molecules for many, many years, and it's quite likely that they are going to be potent immune modulators. Hopefully, you would like to see perhaps within the next 5 to 10 years, we would certainly be in clinical trials.
Oh, that's really interesting. I think you have convinced me that worms may have a role to play. So if you're enjoying our stream and you enjoy getting news about MS research, make sure you go to our website www.msra.org.au and subscribe to our monthly newsletter. Also, go to Facebook and like and follow both our pages, MS Research Australia and Kiss Goodbye to MS. I'm now joined by Dr. Riccardo Saccardi, all the way from Italy and a world expert in hemopoietic stem cell treatment. So Dr. Riccardo, what is stem cell therapy?
Well, first of all, I should define a stem cell.
Yeah, that's a good start.
A stem cell is a cell which is able to divide and proliferate, but at the same time it can give rise to a different population of cells, such as the blood cells, which are red cells, platelets, and white cells, including the immune cells. So the blood cells are originated in the bone marrow, and what we do in clinical practice is a stem cell transplantation, which is the eradication with a high-dose chemotherapy of the bone marrow of a patient, and the regeneration of the bone marrow using stem cells either of a healthy donor, which is the allogeneic transplantation, or the stem cells of the same patient, which is the autologous transplantation. Every year, it's a very well-established procedure worldwide, Every year, about 100,000 procedures are carried out, mostly in oncology and hematology, let's say leukemias and lymphomas. In the last 20 years, we started to use the autologous transplantation also for autoimmune diseases, including MS. And about 1,500 patients has been transplanted worldwide for MS, and about 1,000 of these patients were reported to the registry of the European Blood and Marrow Transplantation Society, which is the largest registry worldwide. And this allowed us to monitor the outcome, side effects, and I say the overall process of the transplant in MS.
Right, okay, so this is an ongoing area of research. So has that research kind of indicated what sort of patients would benefit most from this sort of treatment?
We could say that hematopoietic stem cell transplantation is a sort of strong anti-inflammatory treatment. So the ideal target of this treatment are MS patients with a relapsing remitting form showing evidence of active inflammation both in the clinic, so with relapses, and in MRI. When the patient switched to the progressive phase of the disease, the efficacy of the procedure become lower and lower. So the ideal patient is a patient with an active form who does not respond to the conventional treatment. This is a very important point. There are patients at the diagnosis which are put on first or second line treatment, respond very well, no lesions at MRI, no relapses, so those patients should stay on their treatment. But just for that subset of patients with an extremely aggressive disease, and the patient who progress despite the administration of approved treatment, stem cell transplantation can be a clinical option to rescue them.
Right. So people that have kind of an active and kind of highly inflammatory disease. So what sort of risks are associated with this procedure?
It is an aggressive procedure because it's based on the administration of a high-dose chemotherapy. So when we administer the chemotherapy, the blood cells tend to decrease and get to zero. So for a couple of weeks, the patient have a very low immunological defense, can be exposed to the risk of hemorrhages or anemia, so need transfusion. We have to keep the patient in a protected environment. After a couple of weeks, the stem cells have done their job and the blood cells start to rise, but still some degree of immunosuppression can stand for 2 or 3 months. So the risks are mostly related to the severe immunosuppression, which is also the mechanism of action of the transplant, which is able, through this procedure, to reboot, or if you like, to reset the immune system, and is able also to induce sustained remission for many years in which patients do not need any other immunosuppressive treatment and are stable without relapse or progression or even new lesions at MRI.
So what sort of evidence is the research giving us for the length of kind of treatment or effect of hemopoietic stem cell therapy?
Let's say there are a number of papers now published on patients who receive a transplant for MS, showing that the immune system has been renewed deeply. It's a long process. You find let's say, the clues of this deep renewal even 2 years after the transplant. So at the beginning, when we started, we thought that the mechanism of action of the transplant was just to erase the cells which were generated by the immune system and which were attacking the brain and the central nervous system of the patient. Then we realized with time and with a number of experiments that the mechanism of action is much more active. So the immune system, if you like, has been put back in the immunological clock of the disease to a state of tolerance, which was pre-existent before the onset of the disease.
So many patients go abroad for HSCT. So there's differences do different clinics show different kind of levels of efficacy, and what kind of factors should be considered? Let's say there are two levels. One level is the transplant technology. There is not yet an agreement which is the best transplant technology to use, but the results are extremely reproducible. If you read the papers published from Sweden or Italy or United States or Canada, the results are very similar, which is, let's say, reassuring, because it means that the technology provides reproducible, you can duplicate the data. Then there is a second level, which is let's say, the feasibility of the center which provides the treatment. It is still an aggressive treatment, so we recommend that the procedure are carried out in an experienced center within a program which is approved by the competent authority. So there must be inclusion criteria, for instance. So if a patient get in touch with the center and they more or less ask which is the disease, but they do not investigate the phase of the disease, the treatment administered so far, that means that maybe it can be, let's say, some more commercial target than scientific. So each year, and we've had a lot more drugs for relapsing remitting MS. So where does hemopoietic stem cell therapy fit within the kind of modern treatment landscape?
The first transplant for MS were carried out at the end of the 90s. And despite let's say, the availability in the market of new, very effective drugs in the last years, there is a growing curve for the use of transplantation. So it's difficult to make, to foresee what will be the role of transplantation in the intermediate or long term. Probably in the short term, so in the next few years, it will still active and useful as a clinical option for those patients who, despite the introduction of new drugs, are resistant and progress in the disability in the flare.
I suppose MS is a very varied disease, so not everybody's going to respond to treatment, and they're not always going to necessarily respond to hemopoietic stem cell therapy either. So that's been very informative. Thank you. So if you've enjoyed the stream and you know someone who may also enjoy the stream, you can share it. Just go to the website, share the link. Also make sure you go to our Facebook page, like and follow us. So that's both the MS Research Australia Facebook page and the Kiss Goodbye to MS page. Well, so now I'm joined back by our four experts. Welcome back and thank you. So we do have a number of questions we've received from our audience. Now, unfortunately, we probably can't answer them all. We probably just don't have time. And of course, we can't answer some of the individual kind of treatment questions that we've received. But before we start, I do believe there's been some exciting research news recently announced. So Lisa, maybe you can kind of run us through that?
Yeah, so just in the last 2 days, we saw a publication of a really interesting clinical trial that's taken place in the United States. So when I was talking about myelin repair before, one of the things that researchers are trying to do is look at existing drugs that are already out there that have been approved and have been through safety testing for other conditions. This is called repurposing of drugs. And there was a group in the University of California, San Francisco, who developed a high throughput screening technique to look at thousands of drugs in a very short space of time, using tiny fibers around which the myelin forming cells can grow, just in tiny little dishes in the lab. So you can screen thousands of drugs at a time. They did this a couple of years ago and had 3 hits that were really interesting, and one in particular was a sort of generic antihistamine drug that showed really good results in the dish in terms of myelin repair. So they really quickly pushed that through into a phase 2 clinical trial with the support of the National MS Society in the US. And the results of that trial have just been published with really exciting results. So they've used a technique to look at the speed of nerve transmission, because the speed of nerve transmission is related to how well the nerve fibers are myelinated, how much myelin they have around them. So they treated people with MS who had existing nerve damage, who are, not at the beginning of the disease, but sort of were a range of places along the disease. And they found that treating with this particular drug compared to a placebo speeded up nerve transmission. So it's the first time really that we have seen some really exciting results come out of a myelin repair therapy. Obviously it's phase 2 trial, there's a lot more work to be done, but with it being a pre-existing drug, it can help speed up the journey that drug needs to take in terms of regulatory authorities looking at the trials and approving the drug. So it's really interesting, as I say, early days, but really nice development, and the first time we've seen this.
And of course, because repairing the myelin is a great way to kind of reverse damage and kind of restore some function. So that probably leads to a next question. We've got a lot of questions from our audience about how far we are off from a cure, and what does a cure actually mean. So does anybody want to grab that one?
Well, I can start with that. So I think for me, thinking about a cure or cures for MS is the idea of stopping the immune system from attacking the nervous system, but also repairing any damage that has already been done, regardless of how early in the disease that is. There's a certain amount of damage that's done. So being able to reverse that is really important, and that's where the myelin repair, so the immune cell therapies that we have, but also being able to reverse that damage. So if you'd asked me 2 days ago, I'd have probably said that we're quite a long way away from being able to reverse that damage. It's looking more promising with this discovery. Still work to be done. I think there's still work to be done, but we're looking. It's looking much more promising that we'll ultimately see probably combination therapy that tackles the immune system and tackles repair at the same time.
Right, yeah.
And so I'd like to add, the other aspect of a potential cure is obviously to detect people before they've got significant disease. So there's been a lot of work on MS risk genes, those sorts of things, and these sorts of genes, hopefully, as well as other techniques, may be able to allow us to detect people before they've got significant disease, and that's when the experience from the other therapies hopefully will be even better. Yeah.
So Riccardo, often when people talk about stem cells, they're talking about regenerative medicine. So can you talk to us about what hemopoietic stem cells are and how it fits into regenerative medicine, or not, as the case may be?
It's a good question. Hematopoietic stem cell transplantation is a very established procedure, but it is an immunosuppressive treatment in this case. It doesn't have any regenerative aims. Regenerative medicine using cellular therapy, that means using stem cells to regenerate or, for instance, to repair previous damage, is still at the experimental level in the animal model. Just a very few trials are starting now for using neural stem cells with the attempt or the aim of repair the cerebral damage. But we are still back in this field.
So it might be a combination of stem cell therapies and some of the other kind of myelin repair drugs that are being trialled. So keeping with the therapy kind of questions, Sheila, we've got a question: is if someone's already had a drug that modulates their immune system, can they still have worm therapy?
Again, I'll start by saying worm therapy is in the early stages of development. So yes, knowing what we know about how these worms work, I don't think that would preclude anyone from taking worm therapy. In essence, worms could be seen as just an additional type of immune therapy. whether it would then be the first line, second line, or so on, but it would certainly fit into that same family in that you're regulating the immune response or you're stopping that immune response that mediates damage. So the worms slot similarly into that same family of drugs, I guess. The dream would be is that they're more effective but less side effects. So certainly somebody who's been on immune therapy, they wouldn't have any outcome of that would impact or prevent the worm therapy from working. So certainly not, and it wouldn't preclude anyone.
Okay, that's good to know. So another question we get commonly asked is, what is Australia like for treatment options? Like other places around the world, do they have more treatment options than we do have in Australia? So Lisa, maybe you can answer this question. How does Australia fit within the world community?
We're extremely fortunate in Australia that all 13 of the currently approved MS medications are available on our public health system through the reimbursement scheme that we have. So all of those therapies are available for clinicians and patients to work together to work out what is the best option for them. And we're also not restricted in Australia as to which medication we have to try first. So there's, the doctor and the patient can work together to work out of all of those options, which one is the most appropriate for them, and they can go straight to that one without having to sort of scale up through a different range of medications. So it hopefully means that we can, as early as possible, treat the patient with the right therapy at the right time. And choosing the right therapy is not just about how effective it is or how safe it is. It's also really individual for a person's life circumstances. For example, whether they're planning a family, whether they have other health conditions that might preclude them from having a particular medication over another one. So it's really great that the doctors have access to the full range of medications here.
Is there anything you'd like to add, Riccardo? Because of course, coming from the international community to Australia, hearing what sort of treatment options we have here and what research is going on, is there anything you'd like to add to that?
Well, I attended the conference and there were excellent presentation, but in particular, I'd like to say that I saw many junior scientists presenting their work, very well trained, and this is usually a good indicator of the good health of a health system. With regard to my specialty, bone marrow transplantation, all the Australian centers have joined the international program of accreditation, so they reported their data to the registry. So I think the Australian patient can have their whatever, cannot have nothing less, they could have anything elsewhere.
Oh, brilliant. So David, is there any kind of evidence that some of these newer treatments can help with cognition?
Yes, as we discussed briefly before, the trials have usually not been designed specifically to test cognition. We're hoping that will happen more in the future. There are tools that are being tested at the moment which we think might make that a bit easier to do as well, more computerized tools, for example. But yes, overall, where it's been looked at, there are suggestions that cognition does improve on some basic measures of, say, information processing speed and attention, particularly where the medications are associated or therapies are associated with improvements in other parameters as well.
Right, okay. So you mentioned kind of computerized kind of training and testing methods. Is there actually kind of some methods that someone could use at home to kind of test their thinking ability?
Yes, that's an area of interest of mine as well. There are online tools now which, for example, are being used specifically in multiple sclerosis registries. These are still somewhat experimental. We have to try and work out what the best tools are, but they're basically designed to be brief tools which can, say in about 7 or 8 minutes, can test somebody's speed of processing, their attention, their ability to shift attention, working memory, those sorts of things, and do that pretty efficiently. And the aim of it will be in the near future, we hope, through things like MS Base, which is a large clinical registry which allows the clinicians to put together all the metrics that are used to monitor someone with multiple sclerosis. But we're hoping that these sorts of tools will be integral to those databases, those registries, so that a patient can do a 7-minute test, say, in the clinic, once every 6 months or 12 months, but also if they want to, they can do it at home. We've got one person who's doing this with us at the moment. We've got 500 or 600 people overall, but of them, this one gentleman's interesting. He does it every 3 days at home. He's rather obsessional, you might say. And whenever he has a slight cold or feels a bit fatigued, we can see that there's a slight decrement in his reaction time. So usually it's on the phone to us and says, am I all right, am I all right? So we just ask him to perhaps relax a bit and not have that nightcap and then do it again the next morning. And he's usually back to his baseline.
So we've also been asked the question, and you mentioned it as we chatted earlier, that kind of healthy lifestyle is a great way to kind of help with cognition. So we've been asked, is there any point in time for a person with MS to kind of really start this?
So start doing testing?
Modifying their lifestyle.
I would have said as soon as possible.
As soon as possible. Yeah. So we'll jump to you now, Sheila. We've also been asked, so of course an infection with a worm can help kind of train the immune system, for a better choice of word. What about other infections?
Yeah, so that's, I mean, it's a quagmire of science, but the idea in the media, obviously we hear a lot about the hygiene hypothesis, and that would have this idea that exposure to pathogens of any description would train and educate the immune system to be more balanced and more regulatory, and that's really what we call the hygiene hypothesis. The worm therapy we actually call the old friends hypothesis, because worms have been here for so long with us, we think we need them a little bit more. In terms of therapy, you have to be careful about which infectious pathogen you would deliver to try and regulate the immune response. We know, for example, a lot of bacteria and viruses would drive the type of immune response that would enhance an autoimmune disease, whereas worms do belong to a different family, if you like, which have a different effect. So in terms of delivering a pathogenic organism, I would only recommend parasites, but certainly in terms of childhood and development and training that immune system, you know, there's lots of evidence to say the children who come from farms have a better functioning immune system than those from very, very clean houses. So yes, in terms of best practice, you know, get out there and roll around the mud a little bit, but in terms of a therapy, I would stick to worms.
Right. Actually, that's really interesting, because that probably leads kind of our next question is, so we're talking about kind of the clean hypothesis and things like that. How close are we to understanding the causes of MS? Lisa, maybe.
You want me to start with that? So we know a huge amount actually about some of the triggers that work together to increase a person's risk of developing MS. So I mentioned one earlier on, which is low UV, low blood level of vitamin D is a known risk factor. Genetics is a big component of that. So what we think it is, rather than being just one individual trigger in every person, seems to be a collection of risk factors that operate together to tip someone over the edge into developing an autoimmune disease such as MS. And so and for every individual, that combination of factors might actually be slightly different. So for someone, they might have a large collection of genes that predispose them to developing MS, and then a little bit of low vitamin D, low UV, and certain viruses that we know are involved as well. Might be the trigger that's needed for that individual person. So in terms of the viruses, the Epstein-Barr virus that causes glandular fever in some people who first interact with that virus in young adulthood or adolescence would develop glandular fever. But most people are exposed to EBV during childhood, and it's just a general non-specific infection, you know, runny nose, etc., that they would experience. So they might not even know that they've had it. But what we do know is that just about 100% of people with MS will have evidence of a prior EBV infection, but 95% of the population have also been exposed to EBV. So EBV on its own is not enough to cause MS, but EBV with other genetic risk factors and environmental risk factors seems to be contributing to the disease.
Actually, that's really interesting, because the next question is all about Epstein-Barr virus. And the question is, how compelling is that evidence? And if so, are we using that to try and develop therapies?
Yeah, so as I mentioned, there is a lot of evidence now that some of the work done in Australia looking at people with the first episode that is potentially a precursor of MS, a first attack. That research called the Osimmune study really strongly linked EBV to the development of MS, and other studies around the world have also shown that. So we've got some strong evidence that it's involved in some way. There's some evidence, Professor Michael Pender up in Queensland has been looking at this for a number of years now with our support, and one of the factors that he has shown, and others as well, is that people with MS may have a genetic predisposition or an environmental predisposition that they're not as able to clear or deal with the EBV infection as other people, and that contributes to the development of MS. And Professor Pender is actually collaborating with some colleagues who have developed a specific therapy that primes a person's immune system to recognise and respond to the Epstein-Barr virus, or to the cells in the body that are carrying the Epstein-Barr virus. And they're doing a very, very early stage clinical trial at the moment in people with progressive forms of MS, just 10 people involved in the trial this time around. And that's primarily looking at the safety of this therapy to check that it doesn't cause any extra problems, that it doesn't worsen the disease. And if that looks promising, they would then move on to a bigger trial looking at the efficacy of that treatment to see whether it can actually help clear the infection and improve the symptoms.
So they're trying to kind of retrain the immune system in effect?
Yes.
So David, we've actually got a question. I think it must have come from a female. It's about multitasking and MS. And so the question is multitasking affected, the ability to multitask affected by MS?
Yes, so we know probably between 40% and 65% overall of people with MS do have cognitive problems, and multitasking is probably one of the biggest complaints I think that people have. It's interesting, we've done some research looking at some of the factors that affect that. For example, we did a study that won what's called an Ig Nobel Prize award, which the theory of that is it's meant to make you laugh and then make you think. We studied a full bladder on the effect of that on cognition. And we did find, which probably something that probably everybody knows, that if your bladder's full, then your cognition, particularly your speed of processing, is slowed. Now that was interesting because we equated that to the amount of cognitive decrement that you had if you were staying up for 26 hours, for example. So that's a model of fatigue or tiredness. And also we related it to alcohol, how much alcohol you had. So what we found was that it was equivalent to staying up for about 26 hours if you had a full bladder, and also to about a 0.08 blood alcohol level. So it's relevant to multitasking. If you're driving your car, maybe a modified one in some way, just to make sure that you can do it safely. And you, in fact, this is what healthy people do without multiple sclerosis. It's scary. They can have a coffee in one hand, they're driving, they've had a little bit to drink maybe, and they've got a full bladder, and they haven't been to sleep for a while. That person is really a danger on the roads, for example. And so multitasking, yes, when you're trying to do multiple things at once, particularly if you've got lots of things happening, and your working memory is not working so well, then it can be very, very difficult to keep all those things online.
Right. So Sheila, another question we've been asked is, and it's something that is of great interest to the MS community, is gut health. Do you want to kind of answer that question? So what role does kind of gut health have?
So I'll give a general answer rather than anything too specific. So I think it's becoming quite clear in scientific research that the microbiota, or the community of things, I guess, in your gut really does influence systemic health. That can influence systemic or general immune health. It's becoming quite apparent that the community of bacteria in the gut does influence that. We also know that there's some talk, if you like, crosstalk between the gut and the brain. So we think that brain immunity can be influenced by the community of bacteria or microbiota within the gut. So gut health is certainly important. The problem is, I think, is defining what that good gut community is. And that's where the research is. We're gathering huge big studies of people looking at their gut community of bacteria to try and determine if we can essentially identify a population of really good bacteria. But also within that, you have to get the right ratio of bacteria, and then how stable is that? So simply by, going for a walk or having a stressful experience or having an unusual dinner can change your gut microbiota. So it's a fluid, dynamic thing, and it's trying to find that community and what influences that community to have a positive outcome on your immune health. In terms of, I'll throw in my worms just because I can. No, it's interesting because certainly we're seeing now that when people who are carrying intestinal worms have a very different gut microbiota to those that aren't. So it even seems the presence of these worms are influencing the gut microbiota. And then the question then becomes, is the worm changing the gut population, which in turn is having a beneficial effect on the immune response, rather than the parasite doing anything directly? So it's this really interesting relationship between everything that's going on in your body holistically. And I think even linking back to what Lisa was saying about there isn't one single factor, and I think that's the challenging thing for us to try and dissect out all of this information, of which there's more and more coming out. So there's so much information, but trying to find that really best scenario. I think in terms of your best gut health, how do we manage that and how do we influence it is going to be the challenge.
Yeah, so one of those factors, of course, is genetics, and that's something that a lot of people with MS are really interested about. They're wanting to know whether they're going to pass on MS to their families. So what do we know? What do we know about genetics, Lisa?
Yeah, so as I mentioned, we know that your spectrum of genes that are unique to you is involved in MS. It's not strictly speaking an inherited disorder. So there are many diseases that are due to one specific gene in the body that if it's different, if it's changed, that can lead to the condition just on its own. MS is not like that. What we have identified so far is that there are, I think I can say this now, nearly 200 genes. There's a publication that's very close to coming out that predispose a person or influence the risk of developing MS. So we can see that MS runs in families. We know this. There are some families who will have 2, 3, or maybe more people in the family that have MS. But for example, even with identical twins, it's not that if one twin has MS, the other one is also going to develop MS. If you have an identical twin with MS, your risk is 1 in 6, which is much higher than the general population, but it's still not a given that you will also develop MS. So the genes plus all of those environmental risk factors work together. And what we've discovered so far in terms of the genetic studies is genes that predispose you to developing MS in the first place. And what has been one of the frustrations, I guess, of the genetic research is that we haven't discovered anything yet so far that determines or helps, it seems to influence what type of MS a person will develop, whether they get progressive MS or how severe their condition is going to be. And so that's something that the international groups are working really hard on now to sort of tease that out and see if there's something, genes that all the genes we've identified so far, the majority of them are involved in the immune system. So we know that immune function is a very big player in the development of MS. In terms of progressive MS, it may be that there are other genes that involved in repair and maintenance of the nervous system, but we just haven't been able to identify them yet. But at the conference, there were 2 really interesting talks that may have given us a couple of clues about that. So one researcher was talking about a gene in cells in the brain that seems to be connected to progression of lesions. And another researcher was talking about a collection of genes that she had looked at, and one in particular that seems to influence the severity of disease, so the relapses and the progression of the disease. So it's really the first clues we're getting announced at the conference about genes that might influence the course of the disease as well as the onset of the disease.
Because that is really important, because that's a lot of people are kind of asking when is there going to be developments in the progressive fields of MS, and I think you outlined that very nicely in it.
The course of the disease as well as the onset of the disease.
Because that is really important, because that's a lot of people are kind of asking when is there going to be developments in the progressive fields of MS, and I think you outlined that very nicely in our chat earlier. So that's probably all we have time for today. So I'd like to thank each and every one of you. So thank you, Lisa, Sheila, Riccardo and David. And if you've enjoyed our live stream, make sure you share it and like us on Facebook.